A multi-systems approach. As scope of practice grows and UK population health worsens, podiatrists are seeing patients with far more complex healthcare needs than at any other time. How are clinicians supporting each other within and across allied health professions to manage this changing landscape? This story for the Podiatrist was written by Katie Smith. Part 1. Introduction. Residents of the UK are becoming less healthy, population health data suggests, and by several measures. Almost 2/3 of adults in England were overweight or living with obesity in 2022 to 2023, a figure that has risen steadily over the last decade. Obesity increases the risk of developing diabetes, cardiovascular disease, musculoskeletal, MSK disorders, and certain cancers. It is estimated that the number of people in the UK living with diabetes is at an all-time high, 5.6 million, while 5.4 million people in England alone are living with cardiovascular disease. And the number of people living with multimorbidity is rising too, from 19.2 million people in England in 2019 to an estimated 35.3 million by 2049. The effect on foot health means podiatrists are treating patients with more medical complexities and health challenges than ever before. Part 2. Complex patient journeys. Emily Haworth is an advanced podiatrist at NHS Wales, specialising in high-risk vascular and musculoskeletal lower limb conditions. She regularly sees patients with challenging health needs. Emily says, conditions vary from bullous diabeticorum and chronic limb-threatening ischemia to post-amputation wounds and osteomyelitis. Whether I'm in an outpatient wound clinic, emergency walk-in clinic, vascular triage, on the wards or at the MSK clinic, presentations are highly complex. As podiatrists, we lead our own diagnostic tests, be it X-ray, MRI, diagnostic ultrasound, microbiology or phlebotomy, and take ownership of the results and act on them. For example, the MSK podiatrists she works with are qualified in diagnostic ultrasound, advanced injections and rehab. Emily adds, we offer a full one-stop clinical portal for all foot and ankle MSK with a podiatry-led clinical MSK assessment and treatment service and minor injuries unit. Afni Shah-Hamilton, owner and lead podiatrist at Tiptoe Foot Care, specialises in acute oncology, working with patients undergoing chemotherapy and radiotherapy treatments. She says, key podiatric side effects are neurology and MSK issues, as well as dermatological complications, including ulcerations. If pre-existing conditions such as ingrown toenails and fungal infections don't get picked up before treatment has started, things can escalate far quicker because these patients become neutropenic. Chemotherapy can also create complex pain issues such as hand-foot syndrome, nail toxicities, and neuropathy. Patients come in and they can't walk due to the excruciating pain, Afni explains. They can't put their shoes on, so they're wearing flip-flops in the midst of winter. There are so many who are at the brink of stopping their treatment because they can't take the pain anymore. Part 3. Highs and lows. Such complex caseloads will naturally have an impact on clinicians. For Matthew Allen, consultant podiatrist and clinical lead for podiatry at Salford Royal NHS Foundation Trust, this is a positive. He says, you get a broad understanding of systemic disease and the effects on the lower limb. Podiatrists within our team feel empowered to manage these patients. They feel they've got the skills to learn and manage these complexities. Treating cancer patients is particularly rewarding, Afni says. You can have a huge positive impact on their quality of life when they're going through so much. In some cases, you've potentially even saved their life because they were about to stop treatment and you've helped them get through it. There are, however, negative elements, she says. It can be tough when you're already running a successful practice to see everyone who needs your help. I have a 6-month waiting list, so I end up seeing some cancer patients during my lunch break and before clinics. We move things around because of their treatment cycles, but it can be challenging. Afni adds, the bit no one talks about is the emotional aspect, particularly when you've seen their journey and they didn't make it. You really get to know that patient, and often within a private practice can end up becoming acquainted with their family, so will have continued contact even after the bereavement. From patients needing antibiotics, X-rays and MRI reviews to advanced wound therapies, a typical day can be stressful. Emily says it's multitasking at a high level, keeping calm, and giving your best to every single patient. I have many clinical hats to wear. One day I'm working on wounds, supporting someone through an amputation and reading call-to-action reports. The next, I am seeing people post-fracture or with complex orthopedic issues. It's hugely challenging but very fulfilling. Part 4. A multidisciplinary approach. Matthew's department is heavily involved in its multidisciplinary team, MDT. This includes multiple specialists, an orthopedic surgeon, diabetologist, endocrinologist, microbiologist, plastic surgeon, and vascular surgeon. He says, we've got these people at the top of their field feeding into our patients. Over the last few years, that's made us able to manage more complex patients. This has come from learning from colleagues, he adds. There's been a big evolution of MDTs and lower limb patients from it being very consultant, medic-led historically, Matthew continues. We're trying to change that model slightly to be more podiatry-led and follow a more elective type of approach to the MDT by upskilling ourselves in lots of things diagnostically. This means Matthew's team requests scans, and patients now come into the MDT just to have a decision on surgery. We're doing the preamble, which means when the patient sees the vascular surgeon, they've got all the information they need to say whether they need surgery or not. Matthew says the team is also doing tenotomies, which has helped speed up the time in which people are being treated. It also keeps people off an elective orthopedic waiting list, which is squeezed as it is, he explains. Importantly, he adds, our MDT is open to any foot wound, whether the patient has diabetes or not. Streamlining the MDT has meant we're now also seeing leg ulcerations, in line with the National Wound Care Strategy, and levelling up care for those not eligible for diabetic foot MDTs. So how can podiatrists find support as part of wider teams to keep working in these challenging high-level roles? Part 5. Support networks. Knowledge sharing is crucial, says Matthew. Once you learn a skill, the best thing you can do is then give it to somebody else. Eventually, they'll get confident enough to pass that on to somebody else. That's how we grow our profession. Emily adds, colleagues are very important. There is always someone who can support you on a stressful day. Having a great manager who sees the bigger picture, cares about staff and gets involved in clinics is inspiring. Afni, who sits on the Macmillan Cancer Support Allied Health Advisory Board, agrees. I mentor podiatrists at my practice, but also work with organisations on how to improve the lives of cancer patients through podiatry. I'm regularly speaking on the topic, both within our profession but also to other health professionals. The cancer charities I work with have been very supportive in the work I do and keen to improve awareness and understanding. However, she feels that working in private practice, without access to NHS training and support, puts clinicians at something of a disadvantage. There are a lot of knowledgeable private practitioners working independently or collaborating in small groups whose efforts aren't always recognised, she says. It would be great if we could be better at sharing and promoting this expertise. Part 6. Looking to the future. As recognition and trust in our profession grows, our scope will continue to expand, Emily predicts. We have an increasing number of PhD podiatrists and those in research. Seeing research and audit as an integral part of all clinics should be part of the norm, as well as speaking at global conferences and proving our value. For podiatrists wanting to undertake training to treat more complex patients, Matthew says, you can do it through an academic route. There are advanced practice courses covering clinical, leadership, teaching, and research areas. In addition, Coventry University and the University of Salford are currently developing new enhanced clinical practice training programs, including apprenticeships aimed at supporting career progression. Emily adds, strive to be the best you can, question and be curious, be humble and learn every day. We need to look after each other as a small profession and rise together, be kind and lead by example. This job is an absolute privilege and an honour to do. We live around 4,000 weeks on this planet. Let's make the best of our working lives so we can pass it on to the next generation and ease pain and suffering at the same time.